Good morning, good afternoon, good evening, wherever you are in the world watching this. My name is Kapil Nair, and before I introduce myself, I just wanted to take a moment and express my gratitude to the NBCC for offering this opportunity to record for 2021's Bridging the Gap Symposium. I'm very honored and humbled to be here to be able to speak on this topic. This is something that's near and dear to my experience, and it's my lived experience, so I'm very much eager to be able to share my information. I'm just very grateful that it was accepted, and I'm happy to be here in this caliber to be able to speak on this topic. So thank you. As I mentioned, my name is Kapil Nair. I'm a licensed professional counselor in the states of Pennsylvania, New Jersey, Arizona, Minnesota, and I'm currently pending in Georgia. My experience has been in the realm of substance use disorders, so I'm very eager to be able to share this information with you all. I went to school at LaSalle University in Philadelphia, Pennsylvania, and since then have worked in various different capacities. I started working in the nonprofit sector for substance use disorder treatment in a traditional inpatient setting. Thereafter, I worked at a for-profit facility in Pennsylvania, which is pretty much a Florida model in Pennsylvania. And then since leaving there, I've been working in a private practice setting. In addendum, I also am currently employed in the insurance sector. So I have seen quite a number of things, and I'm very interested in speaking on some of my current findings. I have been studying this specific topic of ethics in the realm of substance use disorders for the past 4 to 5 years, and I'm currently in a PhD program, and my dissertation is going to be on this topic as well. So I'm very interested in this specific topic. So I hope that this information is helpful. I hope that it's a psychoeducation as opposed to my bias permeating through. Granted, you will see that my bias is definitely there. So I hope that this provides some insight, some information with regards to how the Florida model of care is kind of operating, and how sort of some of the nuances of the Florida model of care is bleeding and hemorrhaging out into the for-profit and nonprofit sectors. So without further ado, I'm going to jump right into the first slide. So in having this conversation, I think it's really important to start the conversation off with some congressional acts that have been rolled out. 3 main that I want to touch on for this conversation all have impacts on what is now known as open enrollment, often referred to as part of the Obamacare package. And I want to avoid getting political here because I think that folks that were involved in the rollout of these specific acts, those congressional folks, those lobbyists, were all privy to specific information where loopholes could be established. And so I don't think one specific political party is the culprit here. I think this is a conglomerate of a multifaceted issue within the system of substance use disorder treatment. And I hope this information just opens that door for this conversation, hopefully. So before I talk about open enrollment specifically, there are 2 other acts that kind of interplay here. The first is the Mental Health Parity and Addiction Equity Act. This is a specific act that took acuity and put it on the same paradigm as any type of physical or emergent medical condition. So that meant that prior to this specific act being rolled out, mental health and substance use disorders were not necessarily seen at the same quote-unquote weight or the same quote-unquote importance. And so this act kind of paved a way for treatment providers to then be able to have this discussion with insurers on acuity. And so from the realm of nonprofit and from the realm of for-profit, I hope anyone listening to this conversation would be able to sort of relate. There are times, instances, and situations where clinicians and case managers and utilization review folks have to jump on the phone and have this long-winded conversation petitioning for time with insurance providers. Often those insurance providers will authorize a specific amount of care or specific time duration of care or specific amount of units of care. And so what typically would happen is at the drop of a hat for a specific rhyme or a specific reason, insurers would often stop covering specific levels of care. And so what this specific act, the Mental Health Parity and Addiction Equity Act, did was it gave grounds for folks working in nonprofit and for-profit treatment at all specific roles the ability to sort of debate with insurers and say that according to this specific equity act, denials can no longer be done because of the acuity of this specific member and the need for this member to be seen at this specific facility for said mental health or substance use disorder. And so this kind of changes the paradigm and shifts the paradigm forward. Putting mental health and substance use disorders on a higher echelon, if you will, that would be equitable and equal to almost the acuity that we would treat any medical issue. The second specific act is the Affordable Care Act, and this specific act kind of addresses the uniformity and offering, sort of, if you will, a baseline of coverage across the board for those having health insurance. And so that has ramifications with regards to healthcare costs, and it kind of creates a baseline for costs, never superseding a specific amount so as to create, bankruptcy, for example. It also gave a common stance baseline with regards to preventative care and the importance of preventative care. And so this, in conjunction with the Equity Act, allowed for most congressional folks to have this conversation and to be able to pass a bill like Obamacare and open enrollment. Now, there are three main points to open enrollment, and granted, all of these acts are extremely detailed and highly nuanced. I'm trying to simplify it so that we can have a conversation on the impacts and the interplay of these acts with substance use disorder treatment. Now, when it comes to open enrollment, there are key points that we should be mindful of, and one of them is that when an individual has the need or requires a specific level of care when it comes to substance use disorders or even mental health for that matter, if that person were to opt into a for-profit private facility, more often than not, individuals carrying a specific insurance via their employer or their parents' insurance via their employer, they typically do not have out-of-network benefits, which is a standard protocol or standard rubric for for-profit facilities. So in layman's terms, this is a humanitarian effort, the rollout of open enrollment. And I typically refer to this when I teach this topic as the God forbid moment. So in layman's terms, if God forbid something were to happen to me and I needed to have a surgery, an emergent surgery on one of my vital organs, God forbid, my current insurance may not cover that specific procedure. So what open enrollment offers is on the 15th of the month, I would be able to opt in to a specific commercial PPO policy, for example, that would cover this emergent surgery that I, God forbid, would need. And so without this opportunity, my current insurance would probably have an offset cost of $50,000 to $60,000 for said surgery. That means going through my current insurance, the insurance provider would cover everything but 50 to 60 grand of the surgery that I would need to survive. Now, to offset this cost, what Obamacare, the Affordable Care Act, and the Parity Act allowed was opting into a commercial PPO policy to offset that overhead. So on the 15th of the month, if I purchased a commercial policy that was able to cover the said surgery, my overhead cost would then come down from 50 to 60 grand to maybe 5 to 10 grand. And so the recurrent theme with this idea was to provide a humanitarian effort so that if, God forbid, a massive surgery or a massive life situation happened, you wouldn't have to declare bankruptcy alongside of having a health condition. And so this is the beauty of what Obamacare and open enrollment was supposed to be. Now, there are folks that sat on the board when this was initiated that were definitely privy to specific information to allow for loopholes to exist all the while. In my dissertation, I'm planning on proving that point, but for now, I will leave it at that point. So that, in a nutshell, is what we look at or what we're talking about when we refer to as open enrollment. These three specific acts interplaying with each other as it relates to substance use disorders and sometimes also mental health. So I'm going to take a moment here and start speaking about the levels of deception. Now, please forgive me in advance. Again, I'm not trying to be extremely biased here. I'm just trying to present information as I've found it. Additionally, the levels of deception point, this entire array as it relates to the Florida model of care and substance use disorders is extremely complex, convoluted, and multifaceted. So I tried to organize it in the best fashion that I could. Granted, it's still kind of confusing. So I apologize in advance for that. But let's try. So with the levels of deception, kind of our normal news media markets have kind of deciphered what brokering is, what body brokering looks like, and have a normal definition of it. I'm going to go into a little bit more with regards to the details of brokering. In addendum to that, I'm going to explore with you all kind of the nuances between brokering and also marketing. So brokering's key points, if we take a step back and we think about kind of where we conceptualize treatment and how typically it was done before the epidemic kind of rolled out. Typically what happened back in the day, way back when, is an individual that was in need of care would often go through their primary care physician or psychiatrist, or, God forbid, they would have to go to an emergency room to basically evaluate or get evaluated and then be referred to a higher level of care, like a detox, and then an inpatient facility thereafter. So there was some sort of natural, organic way of getting connected to a treatment provider back then. And along the way, that organicness, if you will, got meddled with, and it kind of rolled into this subsect paradigm of another epidemic of money making, if you will. So the organic nature of folks needing care were often gone through this middleman, and those middlemen became known as brokers. And so these brokers basically were an inorganic approach to kind of chaperoning people that were in need of help to specific facilities. And those receiving facilities oftentimes would offer a quote-unquote kickback or a quote-unquote referral fee, which was typically charged by the broker. And so you have this money exchange happening from a receiving facility to the individual helping someone in need get into care. And so this gets really complex as we started seeing how clients were sort of sent from facility to facility. And that gets extremely complex. And so here and now, we sort of are seeing a human trafficking, if you will, based on specific insurance policy. And by that I mean those individuals that were involved with brokering started studying kind of the nuances of insurances, specific policies that insurances are rolling out with, nuances of billing codes, and PPO reimbursement rates. So that basically means whatever billing code a provider is submitting for, these brokers are evaluating the reimbursement rates that the facility is then receiving through their billing party. And so we see this human trafficking based on policy, meaning an individual seeking care in a specific state would go to that respective level of care knowing that the broker was getting a kickback for sending that individual to said facility. All the while, the broker is also privy to reimbursement rate information, so they know for sure that the facility is capitalizing on this client. Further, those nuances based on specific state and based on specific insurance policy allowed for the broker to then take the client from that said facility to another facility in a different state to then maximize the next level of care and or the same level of care reimbursement rate. So pretty much in my conversations with brokers, current day brokers, they attest that their role is similar, if not exactly identical, to marketers at this juncture. And because of media and because of all the information that we've been privy to, most of the brokers have received a negative construct or a negative connotation and sort of a stigma for having this, mysterious guise of altruism when it's really an underlying malingering for secondary gain, that being money. And oftentimes in my conversations with marketers and even brokers, they often would attest that there would always be 2 degrees of separation. So a broker is kind of in this grayscale in between employment with a facility, contracts with a marketer, and just a random layperson going to meetings. And so this was also somewhat insidiously done, because if there were repercussions or ramifications for a specific facility, and federal agents or whoever it is goes through sort of all of the employees at a specific facility when repercussions are due, typically the marketer would be a 1099, and so not necessarily on record as far as HR is concerned to be employed with the company. And so sometimes that loophole inhibited the marketer from seeking or seeing any type of repercussion. Furthermore, if the marketer was to relay that a broker was working for that said facility, that broker existing in that grayscale, again, is another loophole. So the broker wouldn't necessarily see any ramifications either. And this, in total, is the reason why we have this carcinogenesis of this revolving door of individuals in and out of specific treatment. And by carcinogenesis, I mean the interstate play of human trafficking of individuals in need of care going from, say, Florida to Southern California or vice versa. And now we're starting to see it in the Northeast, so in the tri-state area, New York, Pennsylvania, New Jersey. And it's hemorrhaging out even further. I've seen brokers and marketers attest to the same phenomenon in places like Ohio, Arizona, Minnesota, and even parts of Texas. So when it comes to marketing, if we juxtapose these 2 specific roles, the only caveat in my conversations have been the leveling. And by that I mean there's 2 specific approaches that this type of poaching happens. Brokers typically in the past have been known to go to meetings, AA, NA, Al-Anon, Nar-Anon, support groups, even groups, to seek individuals in need of care, speak to family members, concerned about a loved one, and the list goes on and on. So the ground level marketer still occurs. And again, in my conversations with marketers, they would attest that their role is almost identical to that of a broker. The only nuance here is that the role of the marketer is less negatively connotated, and therefore it's acceptable. Therefore, they can still continue practicing under the guise of this different name. So we have ground marketing, which consists of pretty much everything I spoke on with regards to brokers. They go to specific AA, NA, Al-Anon, Nar-Anon meetings, support groups, grief groups, family groups, and they sort of monitor everyone that's there. And if they catch wind that anyone is susceptible to relapse or is about to relapse and or who has relapsed, they go back into the same cycle of referring those individuals into facilities, again for those kickbacks, again for those referral fees. Ground marketers kind of also participate in these predatory behaviors where they are kind of staking their ground and referring to specific facilities from said meetings. In addendum to this, they also are in touch with all of the facilities in the area. And if you equate facilities to kind of university setting, each month there's a cohort of individuals that are graduating from a treatment facility. And if they're not stepping down to another level of care, oftentimes they typically will just go to meetings. And these marketers will then start monitoring alumni, if you will, of a specific treatment facility. And if they catch wind of a relapse, again, these marketers will start contacting those individuals to get them back into a specific facility. And again, the cycle continues with referral fees and kickbacks. Oftentimes, these marketers are falsely making promises to folks, selling the facility and sometimes overselling the facility and the amenities, and including things that typically aren't offered. In addendum, they offer a la carte services or special requests and accommodations so that individuals would then be enticed to go into a specific treatment facility. And this gets folkloric, but I've heard of individuals being paid to be in treatment. I've heard of individuals being offered Suboxone to be in treatment. I've also heard of individuals being able to coexist with their partners in the same sober dwelling, all the while engaging in treatment. So the list goes on and on. The other phenomenon I've seen is this aerial attack, if you will. And so pragmatically, anyone who's ever gotten a speeding ticket could attest to this. But the day after, or sometimes even the day of receiving that speeding ticket, all of a sudden in your mail, you receive an onslaught of articles in the mail from attorneys in your area that sort of promise reducing cost, reducing points, reducing your sentencing, and getting all the repercussions off of your table, basically. And what I found in my research is that those attorneys use this specific program called LexisNexis, and this is a common program that's used that can filter all folks that have received any type of legal ramification, and it allows for attorneys to sort of advertise their service. What I've found recently is that marketers are also using this specific program, and it kind of works similar to a Google search where you can sort of filter out options. And so these marketers are filtering out and they're searching for individual first-time offenses that are nonviolent, DUI, drug paraphernalia, or possession charges. And they're creating these cold call sheets. And so they print them out and they hand them off to people that they work with that are operating in these call centers. And they physically will cold call individuals and start petitioning and offering services of a specific facility. Now, the cycle again continues here with referral fees, kickbacks, and the entire regimen of brokering that I already mentioned. And it gets a little bit more complicated as marketers that are responsible for bringing a client in from another facility would then also owe that facility in good faith. And simultaneous of that will go through the entire paradigm of acknowledging the insurance reimbursement benefit and the maximum utilization for that specific level of care to continue interstate, quote unquote, human trafficking of clients for maximum reimbursement guaranteed for those receiving facilities. And so, as interesting as this is, it's also intensely alarming. And I couldn't help but think of Wolf of Wall Street while writing this and also continuing my research. And so in my conversations with former brokers and current marketers, a lot of them would attest that these facilities, in addendum to offering in addendum to offering kickbacks and referral fees, are also offering full-time base salaries, and they also offer awards. And so one marketer specifically mentioned that she was given a base salary, including a commission based on the amount of admissions that they had per month. And so many other marketers attested that they were given individual quotas and then also a team goal. And this all was done to incentivize the individuals coming into a facility. And it was almost as if if the facility wins, the individual marketer wins as well. And this commission structure, base salary, commission for X amount of clients' admissions per month, including an addendum individual quota that would award you an additional bonus if you met it, including an additional team goal, all reminds me of Wolf of Wall Street. And so essentially these marketers are body brokering, but it's under a doctored construct to make it sound more legal, less negatively connotated. And time again in my conversations, oftentimes they refer to heads being part of it, meaning heads in beds. So as to maximize the revenue cycle, they wanted to maximize the population within these facilities per month. Because, quote unquote, at the end of the day, it is still a business. And so if you look at it from a macroscopic lens, this end of day, it's still a business. It's all under this guise of an altruistic, I want to pass the message forward and give someone in need of help they deserve, with this malingering touch of, I'm also going to make sure that my bank account looks good. And this is what I've been finding. So those are the basic nuances of brokers versus marketers from my firsthand lived experience. I do want to continue this conversation and talk about current convoluted practices and hopefully provide an insightful conclusion, and maybe even discuss an interplay of those specific acts with the substance use disorder treatment. And matter of fact, let's start there. So what are the impacts of open enrollment and substance use disorder treatment? So with open enrollment, again, reiterating that knowing most folks don't have out-of-network benefits to meet the for-profit facility's need or baseline, most folks have Medicaid or Medicare, or they have commercial insurance that doesn't necessarily have maximum out-of-network benefits that these for-profit facilities are requesting or billing for. So the first thing that's seen time and time again is this recurrent idea of scholarshiping individuals for treatment initially. And on the 15th of every month, folks can apply for specific PPO policies, commercial PPO policies. And that means that marketers could potentially entice or encourage clients and their families to purchase a specific PPO commercial plan. Now, I want to highlight that moment because it's fully aware and marketers are cognizant of the fact that it's completely illegal to pose as an insurance broker. However, prefacing a conversation with a family or a client stating that they're not an insurance broker, but again, with that altruistic guise, if you want to get your family member or yourself help you need, you should probably purchase this specific insurance plan, all the while being privy that the reimbursement rate is going to be specific and high for that said facility, all the while knowing that the marketer is going to be getting a referral fee, all the while knowing that the marketer potentially will also get a kickback, all the while knowing that the marketer is also based on this commission structure for gains. So there's this recurrence of altruistic manipulation of parents looking to save their kid, or an individual looking to save themselves suffering with addiction. It's this recurrent theme of guise of social welfare. And we've seen this before, and we'll speak to it in just a moment. As it continues, if you look at a specific commercial PPO policy, typically that cost is between $350 to $400 per month to have that specific insurance. Now, with an in-network facility, typically there's a max rate that insurance will reimburse for it. With an out-of-network commercial policy, those reimbursement rates skyrocket. And so I previously worked at a facility where a level of care, like a detox day, was in the range of $5,000 per day that was being billed for. An inpatient request was being billed for $3,500 per day. PHP in the ballpark of $2,500 per day. IOP, $1,800 per day. And with outpatient services for a commercial PPO policy, it has no defined limit. So going back to that in-network versus out-of-network rate. So the max rate, for example, for an in-network facility being $1,000 per day for, say, a detox stay. The out-of-network facility can upcharge that stay to $5,000 per day. Now, insurance sometimes has no other option but to pay that $5,000 billed rate. But whatever is offset, that $4,000 difference, unfortunately gets billed to clients as it's the client's request to go to an out-of-network facility from the vantage of the insurer. And the insurer is not fully aware that the marketer is enticing or coordinating or trying to get the client into a said facility to use the out-of-network benefit. But the fault ends up falling on the client. And time again, I've had conversations with former clients that would attest and report that they were working on their recovery when all of a sudden they received a bill in the mail between $30,000 all the way up to $300,000. And so we have this hemorrhaging of funds from insurance companies to pay these premiums that these out-of-network for-profit facilities are kind of quoting. And whatever is left unpaid goes to the client to foot the bill. Now, oftentimes in my conversations with clients, they would go and say that they didn't have the money to pay for this specific service. And so we didn't know what else to do. So they would call the insurance provider and the insurance would say, okay, well, there's nothing else we can do. We can't help you. This is a service that was already provided for. So they would ask them to speak to the billing company for the facility that they went to. Now, the billing at the facility company would say, don't worry about the bill. Feel free to tear it up. Because what they would do is send the bill to collections. Now, later throughout all of my research, I found that at the end of the fiscal calendar year, these facilities would then write off whatever was unpaid, meaning the $4,000 between the in-network and out-of-network facility upcharge, basically. Whatever was due but was unpaid by the client would be written off as charity care. So that would be a tax deduction at the fiscal calendar year. Another loophole. So what's really happening with these scholarships? If an individual is admitted, typically what I've seen is if the individual has Medicaid or Medicare, those individuals are typically admitted and awarded a scholarship for 14 days. And so what the directive is from all the owners and operators of the facility is that everything needs to be documented. That means all family sessions, individual sessions, psychiatrist appointments, anything and everything that happens within a facility is documented. And so what happens on the 14th day is everything from day 1 to day 14 that was previously documented on day 14, when open enrollment has happened and the individual then has insurance, that is through the commercial PPO policy, day 1 through day 14 is then back billed to this commercial PPO plan policy. And a lump sum reimbursement rate is then billed for. And the facility then receives this lump sum bill or reimbursement rate rather. And thereafter, from day 15 through completion, the billing cycle continues per the facility, per the billing team. Now, another phenomenon that I've seen is this new push for treatment as opposed to incarceration. And pardon me for this soapbox moment, but treatment as opposed to incarceration would have been a beautiful idea back in the 80s when Black and brown folks were basically thrown into prison on possession charges, and entire communities were ripped apart and thrown in jail. It seems like a dignity thing here and now that because the epidemic has rippled out from inner cities all the way into white suburbia, that treatment as opposed to incarceration is now a thing. But if you look more closely, treatment as opposed to incarceration, if someone's coming in to a for-profit, even a non-profit facility from jail, typically a commercial PPO policy, or any type of commercial policy for that matter, could be acquired through open enrollment. And so these for-profit centers then create a middle group for those individuals that don't have family, that don't have the means to be able to purchase the premium for a commercial PPO policy. That being said, the for-profit creates these non-profit looking like LLCs as a loophole. They name it anything, and money is passed from the parent facility LLC to this fictitious pseudo nonprofit LLC. And money is taken from this nonprofit in order to fund the premiums for open enrollment. And again, if you think about the trade-off here, if a commercial PPO policy costs $350 to $400 per month, knowing that the first day of the first level of care, that being probably detox or maybe even inpatient, is going to be anywhere between $3,500 to $4,000 to $5,000 per day, their cost-benefit analysis is exponential gains. So they are able to acquire revenues that are exponential. And so just as the aforementioned, they initially and intentionally purchase the policies with the highest reimbursement. And so this is technically just massive double dipping. Going back to that point actually with regards to treatment as opposed to incarceration, I've had conversations with for-profit prison systems, and they would often quote $350 to $400 per day per inmate that they're able to generate in the for-profit prison sector. And so I've had conversations with individuals that work in for-profit prisons that often discuss medication-assisted treatment as being something that they provide to inmates. And they're not able to charge much for each day that that inmate receives medication-assisted treatment. So if you juxtapose for-profit treatment with for-profit incarceration or prisons, the prison system is looking quite envious of the for-profit treatment model because they're trying to acquire the same exponential gains. And so what we're starting to begin to see is this emulation of the bad blueprint. And we'll speak to this a little bit more in my final thoughts, but I want to just plug that in there just for now. So current convoluted practices, this further goes on. I didn't know where to place this directly in this presentation, but I thought it was warranted to actually mention it. So here and now, we have counselors that work in intakes, in standalone detoxes or detoxes that are affiliated with hospital systems. And just a side note here, everyone is fully aware that enticement is completely illegal, but there are loopholes that are followed to avoid anything that's transparently illegal or fundamentally illegal, which is very parallel to Big Pharma and their quote-unquote relationships with physicians. But there are non-traceable arrangements similar to what Big Pharma did, especially here and now with the opioid epidemic and the Sackler family and Purdue Pharma, where non-traceable arrangements are established. And so detoxes receive pens, they have gift cards, they have cash pays for referrals sometimes even. There's oftentimes even a fee arrangement where, I have had conversations with folks that received $500 per client that they referred to a specific facility. And so these standalone detoxes, though they looked independent, are very much linked to these said facilities. And each counselor at a detox is affiliated loosely or closely with a specific facility. And so coercion, again, is illegal, but there are tactics that counselors are often involved with or engaged with that pass marketing information from a specific receiving facility directly to a client. And so there's no organicness in this counseling dynamic as they're doing their biopsychosocial and intake assessments and monitoring specific clients. They're also pushing this malingering agenda onto this specific client to go to a specific designated facility, all the while knowing that the counselor themselves are going to be receiving a specific fee or a referral fee and or a kickback arrangement. So the paradigm is very similar. The other phenomenon I've seen currently is that going back to that point where every 30 days in treatment, a new cohort graduates. With those cohorts, some individuals from said cohort are graduated and are employed on the 31st day of their completion of treatment. They get hired, and this creates a buy-in for all of their peers in treatment as well. They see a recent graduate getting employed by the same facility that they just completed treatment in. And just personal vantage here, I am all for giving individuals the help and giving them the opportunities to live a new trajectory on their life. However, that comes with a giant warning label, because all of the practices that I just mentioned, these newly hired clients also participate in. And from what I've seen, they get enticed by the amount of money that they're able to accrue in a very short amount of time, to the point where these newly hired clients then get kind of in cahoots with these middlemen, these brokers, these marketers, and start guaranteeing payments to clients to be into treatment for 10 to 14 days at a time, solely to meet the allotted X amount of individuals per month, and to meet the quotas that are designated by the operators of these said facilities. So the enticement happens at their bank accounts as well. So here are some of my conclusions. As a brown man, I think it's important to say, if you see something, say something. And in my current consultations, I currently speak and coordinate my time with individuals across the country that are currently working in treatment. And they speak about how they don't want the negative attention, they don't want to come forth, they don't want any attention, nor wanting to create any trouble. They are apprehensive with regards to the amount of money it would cost if there were to be any ramifications with regards to defamation suits or any type of legal ramifications. And to them, I always say, just like I will here and now, if we don't stand up and if we do not speak up, then we are participants of the carcinogenesis of the problematic treatment options that are out there already. And currently we are in a carcinogenesis, the Malcolm Gladwell tipping point of these faulty treatment centers progressing across the country. And there are accrediting bodies that are allowing for this to happen full force across the country as well. So the onus absolutely falls upon us. So what can we do? Briefly, a roadmap, if you will, is speak to your supervisor about your concerns. Reach out to your mentors about your concerns. Try and connect with a lawyer in your area. Speak about your concerns. In addendum to that, contact the ACA Board of Ethics. NBCC also has options for consultations. Contact your malpractice insurer. They offer free legal consults as well. And they will also be able to give you a roadmap as to what you have to do in accordance with your specific state. Follow the directives of your lawyer. an addendum to state regulations, your lawyer will also be able to walk you through exactly what you need to do. I found beneficial to get in touch with a lawyer that was also a PhD psychologist to be able to bounce ideas back off of, and also get a very strategic map as to how to go about doing whatever I need to do to assuage my concerns. So those are some specific actions that we can sort of move forward with. In my final remarks, I would like to just say that we are currently in an all-time high of profits over people. And if we look at the Sacklers and Purdue Pharma and the analogs of all the opiates that were created, and we kind of juxtapose that phenomenon with all the analogs of treatment options that are being offered, nothing has been efficacious. And that's the bottom line. And if nothing has been efficacious, then we have to assume that everything that's offered is just not the best option. And we cannot be content with offering not the best option if there's no other option available, because people are sick and dying. And what I've seen from my research is that we've gone from a place of enslaving people to crop product to profit off of, to now we're just cropping people to profit off of. And that's a very crass way of looking at it, but that's genuinely how I feel. And when it comes to treatment as opposed to incarceration, it seems like it's such a beautiful idea, and I think it's a very beautiful, idealistic idea. But I'm very concerned about this just being a continuation of the same bad blueprint at this point. More of the analog, more of the same. It just in a different format that accrues a lot more money for those that are responsible for operating it. And so in conclusion, with regards to bridging the gap, I would just like to say this is extremely important to be mindful of. We are all participants in this, and it's our prerogative to stand up, speak up, and do something, not just for our clients, not just for the field, but more macroscopically for social justice. Thank you so much for your time. Again, my name is Kapil Nair. I hope this was insightful. I'm sorry if it was negative and stigmatized, but I appreciate your time and attention. I hope this was helpful. And NBCC, thank you again for this opportunity. Appreciate it. Take care, be well, stay in touch.